in terms of like costs as well.
Loads of really good stuff. Different team tips. Yeah, definitely. So
also remote meditation lodge. Because it's far away in the neck, you know? Growing the economy, to get more money there, and at the same time as it's actually at the same time as getting the projects that are going to and yes, he was in the UK, I guess it's companies operate there and trying to recycling.
Let's keep it small. I love bubble tea.
So it's even like clearance actually like.
Yeah, just a couple more minutes.
Okay. 10 past.
Yeah.
But yes. Do you want that so we can look at it?
No, it's a leaf. A very irritating leaf.
Oh, it's just a leaf?
Yeah.
Which is kind of the opposite of strictly because you can understand it's actually silly. How to write, figure out ways to
I can't believe that the whole time.
At my old work, my friend sat next to me. She had Swedish and but we were supposed to be multitasking, so someone else would have to sit on her seat and just oh my god.
In Rome, then we should consider a password on my house's operation. In a particular organization. So we finally had to wait for the book to find out how to do that before for one reason, I don't know. We didn't have that as well. Was that so kind of all sorts of things. Let's just see what sticks. How did you get to I used to centre and then
Okay. Alright, can we just get cracking? Yeah.
I think we're just going to go ahead and get started now.
Yeah, especially when you go to the field.
I also wouldn't make a very good teacher. I'm not very good at commanding silence. Hi, welcome. Okay, so I think we're going to get started now. Right, there we go. Practicing my best teacher voice. So I'm Nicole, I'm going to be the chair for today. A quick introduction to me. I am the founder of a healthcare tech startup called Medixus, and we operate across Kenya to connect medics across the continent to collaborate on challenging patient cases and share knowledge. So that's my little tidbit. And we're really pleased that you could all join us today for the third in the series of the Future of Public Health in Africa events. So we've already had 2 extremely interesting events, which I think some of you were at, covering the 5th non-communicable disease, so we were looking at mental health on the continent, and then we also explored re-emerging infectious disease. Today's going to be no different, so we're going to have a really interesting topic, which I'll hand over to Nick to briefly introduce to us, as well as giving us some context to BOBAB.
Yeah, thanks Nicole, and welcome everyone. I don't know about you, but I had an awful journey on the tube today, so thank you so much for battling and making it here. So just first of all, a very, very quick introduction to BOBAB, who we are, what we do, and why we do it. But have I just bear with me for a second. Yeah, so as I was saying, BOBAB, who are we? We are a social enterprise. We are for profit, but the profit we make gets reinvested into our community. And we're an event streaming and peer-to-peer networking platform dedicated to connecting science, tech and business professionals working in and for Africa. We've got the ambition, pretty ambitious ambition, to accelerate science and tech on the continent. We want to do that by playing a role in spotlighting and celebrating, shining a light on the latest commercial, academic and charitable innovation, and really importantly, the people and the organisations on the ground that are making it happen. We work across 5 core areas: agribusiness, we just finished a series with Newcastle University on agribusiness, energy, public health of course, WASH and urbanisation, but we don't like to work in silos, so we don't just look at one area, we look at multiple different areas, how they intersect and why that's relevant. As we'll see today when we're talking about money, of course. In terms of how we work, we've got some pretty basic but effective ways of bringing people together. First of all, we explore. So we host events like this, designed to bring experts together in person and online. We are live, there's a camera behind you, and we'll live streaming directly across the BOBAB platform. We promote, as I said, a really important part of what we do is we wanted to spotlight the best scientific, academic and commercial innovation that's happening on the ground, and we connect. So whether that's in person or online via the BOBAB platform, we want to make it easy for people to find other interesting people, to have a conversation, to chat, to exchange knowledge and information. And our community is growing, I'm happy to say. If you haven't already signed up to BOBAB, please do, you're missing out. And it's a really passionate, it's a really engaged and professional community. At the moment, the split is just under 50% of the community is based on the continent, which is the way we want to keep it. Around 28% here in the UK. 13% in North America, and the remainder split between Latin America and Asian subcontinent. So the interesting thing for me when I just look at people as they sign up and where they're coming from is that there's a global interest in Africa, and there's a global community that's really passionate about applying technology and science and business to addressing some of the fundamental challenges and opportunities that the continent presents. And we'd love to work with you or anyone you might be connected to, and there's lots of ways to get involved. So this event we've done off our own back, but the agriculture event we just finished last week was a series we developed in collaboration with Newcastle University. They're very keen to showcase the research they're doing. We're very keen to showcase the research they're doing, and it was a really good collaboration. Of course, you can also get involved with, You can also get involved with contributions through content. We've just launched a new projects feature last month. So if any of you are working on any research or any interesting collaborations or interesting charitable initiatives, we've just launched a really cool project page on there, which makes it really easy for you to promote your work, and we'll connect you with interesting people who want to find out more about what you're doing. And that's it. I'll wrap up BOBAB there and really just build on some of the stuff Nicole said around the series. So it's been really, really interesting. We did the series of 3 events because, well, of course, public health in Africa is a hugely complex topic. We can never hope to get it in to a single 2-hour event. And as she mentioned, we started off looking at infectious disease. We looked at challenges around capacity building in particular, in education, in terms of challenging re-emerging infectious disease. We tried to get past the sort of stigma of diseases like Ebola, and it was really fascinating. What came up in that event was, of course, the topic of money. How do you pay for capacity building? How do you pay for supporting infrastructure and disease prevention and control? The second event, we talked about mental health in Africa, which, in my opinion, and certainly lots of people in the room that day, is an underexplored topic. Not enough significance is given to it, not enough attention is given to it. We looked specifically at the role of integrating mental health care provision within existing non-communicable disease and other health infrastructure. There are lots of opportunities for that. There are lots of synergies. There are lots of opportunities where you can embed mental health care provision for the benefit of broader health outcomes, whether that's in non-communicable disease or infectious disease. But again, it came down to money. How are we going to pay for it? How are you going to train people? How are you going to amend a health infrastructure that, by definition, is vertical? It's designed to treat one specific area of disease, often infectious disease. And so that's why we decided to round this series off with a good look at all things money and finance, and to look at just the challenges or indeed the opportunities that we can identify. And I don't need to, but I will anyway, state some of the obvious stats and facts that are out there. A lot of us understand health in Africa in the context of SDGs. The SDGs, needless to say, they're very, very ambitious. They call for an ending of epidemics such as AIDS, tuberculosis and malaria. They call an end to preventable deaths of newborn and women and children under the age of 5. They also have, for the first time, acknowledged the significance of mental health in the context of non-communicable diseases. Africa makes up around 16% of the world's population, but around 23% of the disease burden, while spending less than 1% on health in countries across the continent. Needless to say, here you have an issue. Lots and lots of challenges, but not an awful lot of expenditure. And cash-strapped African governments are struggling with health financing. There's an estimated 66 billion a year not being spent. As a result of that, around 37% of all health expenditure on the continent is out-of-pocket expenses, which means people pay from their own salaries rather than any health insurance or national health service. And about 11% of people on the continent, which is a stat that really shocked me, have experienced catastrophic spending for healthcare every year. Now, of course, that isn't just a case of someone suffering as a result of an illness, but it's a family, it's a business. And that has much wider economic ramifications across multiple different types of value chain. So it's clear that there's some serious issues in public health expenditure. Surely that calls for the private sector to ride in on a white horse and save the day. And of course, there's lots and lots of room and opportunities for private sector investment, but there's also concern that the role of the private sector could be taken advantage of, manipulated, and health systems created in the benefit of private enterprise rather than the public it's designed to serve. This, of course, is set against the backdrop of, if not decreasing, then certainly stagnating donor funding. It's not as much as you think either. It's about 9% across the continent. Those are stats I found anyway. And that would suggest that if that amount of money is removed, perhaps it wouldn't have such a big impact. Perhaps it wouldn't be such a big deal. But as we know, international donors tend to pay for big ticket items. So, we're talking like national AIDS and HIV prevention programs, talking about inoculations and vaccinations for children. If they suddenly disappear or aren't as frequent, you have much more serious consequences later on down the health system, where instead of preventing disease, you're treating it, and that increases the burden on health systems. So, something of a perfect storm in terms of challenges, but we certainly think, or we say in BOBAB anyway, where there are challenges, there are opportunities. So there are lots of opportunities, whether it's sort of so-called sin taxes, taking more, tobacco, alcohol, sugar, taking more of a hit. There's a lot of potential for pooled resources. If that many people, 37%, are spending that much money on health systems, then surely there's a role for the state to collect that in taxes and revenues. So easier said than done, I know. But yes, there are opportunities out there, and we're interested in exploring them. So thank you so much for coming along and helping us do that. And I'll hand over to Nicole, just to.
Great. Quickly, housekeeping running. Then we'll have Q&A, discussion, and some outputs. And today I'd like you to do something a little bit different during the talks and during the Q&A and the discussion. I would like everyone to write down at least one or two tangible outcomes. So things that you could take away and implement after this session. And at the end of the session, what I'd like everyone to do is share their outputs, and then someone will volunteer to take that output as I'm going to do that thing. And we can update each other on BOBAB, because that's what the platform's for. So we can all make sure that we're signed up to BOBAB, and on the event page there's like a chat, and we can also make a group or a project, so then never again do we walk away from an event thinking what came of that. So we've all got homework basically at the end of today, so write down your homework tasks. So yes, we've got two excellent speakers with us today, and I on what the topic is. I was just saying to Steve before I arrived, I was listening to a podcast and all of them have got something about financing public health, and the experts on this podcast were highlighting that public health is not just healthcare infrastructure in terms of the hospitals, it is health, it's education, it's transport. All of these things coalesce to form public health as we think about it. So it's a huge topic globally, so very topical to be talking about it now. So yes, we've got two wonderful speakers. So we've got Agnes here, who's joining us. She's a partner at GBS Africa, and they focus on helping to advise people on the risk element of investing in sub-Saharan Africa. So she brings us a really interesting perspective. And then we've also got Dr. Lisong Conte, perfect, who's Associate Professorial Research Fellow at LSE. So Lisong is a health economist with a research focus on the economics of infectious diseases. And so between we get today we start with Agnes, who's going to kick us off. So each speaker will speak for about 15 minutes, but feel free to sort of ad-lib, and we can make this quite an informal session today. No?
Oh, goodness me.
Post-technical difficulties. Oh, actually, I forgot. Since we are a small group, and I was meant to do this anyway, if everyone could go around and introduce themselves, just say your name, your affiliation, and what brought you here today, that would be great. So start with you.
Hi, I'm Celia Moore. I'm a volunteer with BOBAB and help Nick with the organisation of these events. I used to be at IBM working on the corporate engagement programs across Africa and Europe, and very interested still in African development and the potential for Europe to really engage and help.
Hi, my name is Tapo. I'm a GP trainer.
There's aid, and the out-of-pocket, which is the teal sort of colour there. And that seems to me where the transition is. It's got a little bit more emphasis and a little less out-of-pocket, which is interesting, and maybe that's something we can come back to think about. Why is the government, or the publicly funded one, not moving? Are we crowding out something there? Is it complementing or substituting? What's the big picture behind that? That graph at the top is just to show that's the current health expenditures percentage of GDP globally, and you can see that Africa does spend, on average, sub-Saharan Africa, I should say, around 5% of their GDP on healthcare. And given these big ambitions for universal health coverage, this is attention. So these diagrams, I'll talk through them rather than try and understand. The one on the left, it got me thinking yesterday, the language, the new scramble for Africa. It's an Economist, in the Economist, an article earlier this year. It's meant to be pejorative and everything, but I think sometimes it is unhelpful to often frame this move into Africa in the lenses of old time, in the colonial days, and then in the Cold War, and now this next tranche, because it's a slightly different set of it's a slightly different agenda here now, and it's somehow I find it like slightly infantilizing and a bit out of date, because Africa's actually had a lot of economic growth. And it's been one of the successes, certainly from 2000 to 2010 to 15. It's starting to slow down now, but there's still Ghana was the biggest sort of rate of growth in their economy globally in 2017. I was reading in the preparation for this. So there's some real interest in going onto the continent, and yes, it's driven by lots of the natural resources. And so there is fluctuation in this global economy. They're quite vulnerable to swings and movements in the global economy, but there is a real appetite to try and work alongside African nation states to make some private sector and commercial benefits. But what's interesting is how much do these spill down and filter down into the health sector. And if we go back to that blue line at the bottom of the chart there on the top left, it suggests even with this economic growth, maybe funding healthcare isn't necessarily a priority on the continent, and that has to be looked at. So on the right-hand side is this skewed thing that I found and got slightly overexcited about as I look at it now, this diagram. I found it yesterday. It's a McKinsey thing, and I don't normally use that. I've never used that stuff in a presentation, but it's a really nice way of setting out. So what we have is the bubbles are the size of the economy, and really the biggies are Nigeria, Angola, and South Africa. And then as these bubbles rise, it's about their risk, actually I can't see the
real GDP.
Their real GDP, and so how much money they've got going in, and then also how they're perceived as risky. And the main thing from this diagram is that sort of in that top right-hand quadrant, you've got Ethiopia and Cote d'Ivoire. And these are really exciting spaces to invest in. They say that they're low risk politically, and there's a real potential for return on investment. And then you've got Nigeria, South Africa, big in terms of sort of the budgets, and they tend to be sort of in the middle there. So they're not as extreme in any terms in terms of risk, political risk, or GDP. Okay. And so financing the future, and so at the end, the flip of that is we're always sort of chasing the next thing, and we don't necessarily consolidate where we're at. And so at the moment, you can't, if we're doing, I would say, global health bingo. So tick SDGs has to be mentioned, tick UHC, and so sort of innovative financing. And I'm being deliberately sort of antagonistic here, because they're all actually really, really important, and it helps people coalesce around ideas and feel that they're part of a bigger picture and a direction of travel. But in terms of when you start unpicking those things and the details, how does that play out in country? So we did some work recently with fantastic colleagues in Ghana and Uganda around HIV targets, and it was 90, 90, 90, and that's what the big new music is coming out of Geneva, and it's helping in terms of advocacy and financial sort of trying to bring money to the topic. But we're thinking, how do all these diktats or these targets, should we say, land in country? So when you go to Nigeria or you go to Uganda, and then you've got that, and then in malaria we've got where we want to be in 2035, you've got a UHC agenda. How do they play out? And it was really interesting just talking to people around. A lot of people are just tasked with what their target is, and there's not a lot of cross-thinking. And again, I'm not judging because you're just trying to get through your everyday and do the best you can. But it does create silos of money, but silos of thinking sometimes, and that's not necessarily helpful when we're thinking of public health. The middle diagram there, with the blue and the green, is again just to allude to this concept of transitioning. So if we're talking about future, and sometimes they support countries, but once they get to a particular economic level, they're going to pull back a bit and let the country jump in and fill that funding gap. So that assumes there has to be an amount of fiscal space, so there must be some money there in reserve to spend on that, and there must be willingness to spend on that. And there's some really interesting work going on with colleagues at the University of Ghana, looking at that transition phase, and in Duke University, and I suggest that we follow up with those institutions of interest. And then that top picture there was a paper taken from the Lancet a few years ago, and I'm glad it's really tiny because I don't really follow all the different initiatives. But what it was listing all these different ways of funding. You've got bonds, you've got sort of collective efforts in malaria. There was a thing where just a group of really powerful countries and donors got together and they could collectively buy and bring the prices down of some of these commodities. So some really clever ways of working together to finance things. Okay. Yes. And so finally this idea of public health. What I mentioned earlier, is it valuable to think of public health as a framework for future planning? Because I know that it's really important to have population health, definitely health promotion, health prevention, but more and more, as I taught on the global health, is that there are these transnational, supranational forces that aren't respecting national boundaries, and the money flow seems to be as well global. So what can we control and what can't we? And I think that's a really interesting narrative, and there's lots coming around pandemics, and there's sort of the fright of them, and whether that's a useful motivating factor. And that sort of came around, didn't it, when the time of Ebola and flu, that actually funding in high-income countries, if that money is going to low-income countries, there's a direct benefit for those in high-income countries as well as in low-income countries. And we have a particular government that likes to frame things around that. What is the return on investment to us? And whether we think that's a good thing or not, it's definitely some of the mood music around justifying our spending. And I mentioned a lot of when you went around the room, talked about multi-morbidity as well. So this idea now that you don't just turn up with one condition. It jumps to a later one, is people-centered medicine. And actually it probably is a bit more efficient if I turn up with TB and I also have got diabetes. Let's think about these things at the same time. Because it's going to cost me, but it's possibly a more efficient way of actually getting to the bottom of the root cause. We're all sort of running with parallel medicines and people and services. So how can we think around that context of multi-morbidity and addressing it more efficiently? Resilient and responsive health systems. This is a space I'm moving into more now in my role at LSE, because I've always sort of thought about and frame my thinking in terms of disease, cancer, Chagas, malaria, but actually thinking across systems, governance issues, human resources issues, some of these things that slice in bigger picture ways. We really need to think more around that. The funding doesn't necessarily allow for that, but actually there is, if you start looking a bit deeper, there is this spillover, if you like. There is Global Fund, yes, they look at 3 diseases, TB, malaria, and HIV, but they do a lot of system strengthening actually, directly and indirectly. So this idea of a spillover is something that's quite an exciting space. Public versus private healthcare. I've been deliberately contentious because I don't necessarily think it's an either or an or. I think that both have to come to the party. I am nervous because when you don't have great regulation, private can cherry pick, and of course, it's got different motivations. It needs to make a profit for its shareholders or whatever the course is. So
that's to be expected. But how do you protect the public health agenda from that private motivation? I talked a bit more about this idea of person-centred care. And then, how many of these gains are actually within the context of the health sector? I mean, how much, again, coming back to this issue of control, it's more about water and sanitation maybe, and doing a project, you mentioned housing, I've done recently a project on malaria, trying to look at housing to see if that actually is the intervention. It's not necessarily the only medicine, but it's some other sort of wider multi-sectoral issues. So I think the future of public health in Africa is global, it's multi-sectoral, and there's the case for health is getting stronger and stronger. So more and more when I go and visit places or engage in discussions, yes, it's really important to get the Ministry of Health involved. It's the Ministry of Finance. You want to take really. Because she's got the purse strings, and so if you can make the economic case for well-being and a healthy population to grow your economy, it's really powerful. So that's why, this is my bias. So I'm happy that I like counting and evidence and all the rest of it. And so global health is restless, and as I said earlier, we move from target to target, initiative to initiative, emergency to emergency. But we're not so great at tracking and understanding the drivers of what and what doesn't. And how much these things, I get nervous sometimes about working particularly and if I was at this door. So I don't know the answer to that. But there must be some big picture things that we can learn from the machine. And so then there is an onus to be a bit more conscientious. People are working full-time at full stretch, and ticking lists isn't necessarily a priority when you have a 5-year-old in front of you. And not only using the data, analysing it in a correct way, but making sure it's a useful format, the output. Because no one's reading. No one. Few people read academic outputs in the Lancet, maybe it's more of a journal / magazine. But in terms of getting the data to the people that can actually affect change, it has to be packaged properly. It has to be packaged effectively and timely, not in 2 or 3 years once I've looked at every corner and picked up every stone because I'm nervous about getting something wrong. And I would say it has to be not just the people that are providing the services, but more and more I'm really excited about civil society and the consumers and how they can pick up this information and use it to their advantage. It's something I'm watching with real excitement, that people are just sort of standing up for their rights collectively and as individuals. And I think, again, that prompts the providers to respond to those requests. So my recommendation is, yes, let's just sort of keep going, but thinking about what's worked, what hasn't, and what's that data, what's our evidence base always, who's written that, why, what's the motivation, what's gone into it. Okay. And so that was it. And then the final thing is to spotlight, so I was allowed to spotlight a particular institution or individual. And so it would be the Health Systems Global, and I don't know if anyone's come across this in the room yet. Yeah, they're a really exciting collection of people who really want to health systems. I mean, what is that? You have economics, you have anthropology, sociology, medicine. What systems? It's not necessarily a discipline, it's a collection of people. And to be honest, 20 people will have 20 different ideas probably about what health system are. And so what's exciting about this platform is that they embrace that difference. It's got a really sort of heterogeneous group of people involved. That comes out here in terms of where they are. Lots of activity in sub-Saharan Africa, but all over the World Health regions. And they've also got a really great mix at their conferences, academics and non-academics. The academics in the minority. You get people from sort of funders through to it's really nice. They have it every 2 years. The last one's in Nepal, the next one is in the Middle Eastern region, it's in Dubai, and it'll be my final slide. But it's a really accessible way in to think about health issues. It's a platform that you can reach out as an individual, anyone thinking about this, and it's a very active forum, and I'm learning more and more about it. And, it's not sort of come out probably there, but just to say they have got a drive year, there's quite a few funded shows and there's still time. I'll work more generally as well. So thank you.
Excellent, thank you. So both of those talks had some really interesting themes, I thought, that I'm actually looking forward to getting everyone's opinions on. So for me, some of the things that stood out were around the data to make the right decisions that seems to be lacking, the conversation about the sort of moving goalposts around setting different targets and then us never hitting them and then a new target comes. Exploring the role of the public and private sector, I thought that was another thing that came up in both of your talks, and where does the responsible, for me, a big question has always been, where does the responsibility of the public sector stop and the private sector begin, and at what point is that relationship too muddy? And also the changes in government spending, so why is it that hasn't moved much since 2000? Like, what are the drivers for increasing spend, and how can we get governments to be more aware of that? And then your point too, NHIF, so the insurance provider in Kenya, how I think a lot of people still don't see that necessarily as a provider of quality care. So what's still going wrong with our insurance models that aren't working? So I would like to open the floor up to questions. Don't be shy.
And loads of thoughts. Thank you so much. I've made loads of points, so I'm like struggling to formulate a question, but I think it would be helpful to, just because I remember because you spoke last, Dr. Conte, to maybe deep dive a bit on, you mentioned Ghana, and you mentioned the insurance scheme there. This is also something I know a teeny bit about, because I actually went to Ghana in 2017 to do some field work, and that was the year that you mentioned was the highest growth. And I went to a clinic, and there was no water, there was no paper, there was no drugs, there was no medicine, there was nothing. It was quite shocking, because also, I'd fallen victim to the kind of the way that Ghana's been portrayed as a sort of success story, certainly in terms of economic growth. And I did look a bit into what had gone on there, and I'd just be interested to know if you know more about that situation, which I think could answer some of the bigger questions, like in terms of the government, why is government not spending money on health, but also in terms of equity, because the national insurance schemes have the idea to cover everyone and to cover everyone regardless of income, some even regardless of employment status. And I collaborated on a paper it was very with the Ghanaian actually, and it was very the title was social insurance schemes do not cover the poor. It was quite clear on that. And yet, I have to say, one of my co-authors on that is a big UHC person, and we are seeing a kind of, in countries, UHC equals insurance schemes. Mm-hmm. So I think, I'd just be interested to hear more, on Ghana, but also in Kenya, where this is also similar issues.
Mm-hmm.
Yeah.
So I've been tracking Ghana for a while, because it was one of the first. It started with a community-based health insurance, and it was really exciting, and that ambition grew and grew. And then there's always this tension with these schemes about who gets in, because you have a selection where is it only the really sick that can go in, so it's not sustainable, and all those issues. And so I think, so I'm a massive Ghana fan, so I have to put that bias out there already. And so
with that health spend, you can find that.
Well, there's a transparency and honesty and a willingness to learn and move forward that's there. And there's different times in the political cycle, and we're seeing that play out here in the UK. Health coverage is deemed as a win, and it wins votes. And I guess with Ghana, and there's people so much more experienced to speak to this than myself, Irene Jayapal, Justice Nobinyon, the political economy of UHC, Rob Yates, if you haven't read his work. But I would say that the ambition preceded having the funds. They would spend a lot of time trying to get the regulatory systems in place, and there was lots of people that were exempt. So I think that was the thing. The ambition to cover everyone meant that there wasn't enough money in the pot to cover many. And so that really does have these equity implications then about, are the more vulnerable suffering even more as an extent of this or not? And I don't know the evidence base on that. But I don't know if I can. I don't think I'm answering your question. I'm conscious that I'm waffling.
Maybe like how, so given when I left Ghana, I was very struck with, I don't know what to recommend. I don't know how to move forward. And maybe the same, you know, so other countries like Kenya and things don't fall into South Africa, like don't fall into these pitfalls. Like how can we sort of make these insurance schemes more robust, or should we be going for, like Rob Yates would say, really publicly financed, free at point of delivery healthcare? So I guess it's, how can we work with what we've got as well?
I think one of the challenges in Ghana, I read a report, was an issue around governance, and I highlighted about governance. Some of the money that was meant to go towards UHC really was not, of course, found other very important places to go to. So governance is an issue. The same thing in Kenya. The government has this incredible vision to ensure that everybody has accessible, and every time I hear the politicians talk about it, everybody has accessible, affordable healthcare, and they realize that for their countries to prosper, then the citizens must be healthy. So what Kenya has done is to ensure that the vulnerable, so they have little schemes where the older people are registered. If you don't have work, you have access with the county government, so they're able to track it and ensure that the most vulnerable in the communities have access. Whether it's working, I think in 2008 we had about 8 million Kenyans registered under this, and you can access basic healthcare support. And I think there's a vision. It is the implementation, and a lot of work across our regions. We have this great vision, but how then do we implement it? I think it's early steps. They're taking steps towards the right direction. I think that we talked about the hospitals being very inadequate. It's how do we then ensure that the hospitals...
Rural clinics. Hospitals, usually, this is another issue, like that the money will go to the hospitals, right? And rather than the rural primary healthcare.
I think even within Kenya, though, my experience of NHIF and working with facilities has been that the National Health Insurance have been holding a lot of facilities to ransom to get your NHIF accreditation. Then there are loopholes one has to jump through. So I think that and with healthcare everywhere, it's often a systemic failure. So it's rarely ever this is one point of failure. It's always, so even the big facilities, I won't name names, but some of the biggest private facilities in Nairobi that we work with have said, like, from start to finish, there is a systemic, the systems just aren't in place, from patient walking through the door to being discharged. And it requires a lot of funding to do that. So, and you speak to, within Kenyatta National Hospital, one of the biggest referral hospitals, they also have a huge problem with the lack of funding coming to them. So I think for me, it's almost an interesting question of, even if we get patients covered, how do we make sure they have access to quality care? Because they might have the coverage, but the quality care is not there. So I'm covered to go to KNH, but can KNH treat me is another question.
So I think what the government in Kenya has, I'm not really talking for the government, but what they've done is to ensure that with the National Insurance Hospital Insurance Fund, you can have access to private clinics. So it's not just the national hospital. But of course there is a lot of challenges around that, and of course private hospitals look at money first. Before you could only access the government-run hospitals, but now they've expanded that you can go to private places where you have accessible and quality healthcare.
Sometimes.
Yeah.
Any other questions?
I've got one from an online viewer. Touches on this cost. Hello. Laura asked the question. Touching, I guess, on this issue of multimorbidity, touching on the issue of non-communicable diseases, references, and I guess, Rachel, you can chip in on this as well, touches on the cost of diabetes to the NHS, 14 billion a year, she says. I'm not sure if that's true. Is that true?
Yeah, I mean, I actually don't. I wouldn't at this point in say the whole number, but it is shockingly high.
It's shockingly high.
I think it's like it's over 10% of the whole NHS budget.
Yeah. So, okay, in that context, she asked, is there anything related to that sort of non-communicable disease which could be transferred or to the African context? Are there lessons learned, I guess, in that context from the UK that could be transferred to Africa, or is it a case of leapfrogging and avoiding the horrible mess we're in and trying something completely different?
That's a good question. I mean, it can go both ways. So, yeah, I'm thinking, what could we learn from them as well?
Yeah, well, quite, yeah.
Financing, we can find out how they finance their national health service. That's one thing.
It's falling apart now.
Well, I think that's where we start from, financing. We don't have finances to be able to tackle the challenges we have. So
Yeah, and I wonder if there's a lesson to be learned from the mistakes in our lack in social care here at the moment. So seeing the cost that the lack of social care is now having on the secondary healthcare service, and how we could, on the continent, better educate people in preventative measures rather than treatment. So educating about the rise of diet-based diseases and recognising cancer, because it should have been declared a national crisis in Kenya, but because of the lack of data, the government haven't declared it as such. So I wonder if there's something around that education piece where we're failing in the UK.
Yeah, well, I think that's, I wasn't going to say that, but I'm glad you did. I don't want to say it first, but yeah, what we have been talking about mainly so far is healthcare, and I really strongly believe we should talk about health. And we don't have to say public health because that already puts people off, but health rather than healthcare. So yeah, in order to avoid the situation where a government's going to be, an NHS is going to be struggling increasingly from diabetes. I was recently in India. I mean, their children have type 2 diabetes, and it's the emerging middle class. It's not the extreme rich. It's not the extreme poor, obviously, but it's really shocking. There is something like in the genetic tendency there. In India they actually define obesity as like BMI 23, which is really because that puts you at risk of diabetes, and it's it's just this hasn't been actioned in time, but it's happening so fast, and that's why I think in terms of like the health or healthcare, that however you finance it, however you design the system, it has to be in the context of these rising chronic diseases that are too expensive for any government. So then that's actually a question for all of you. How can we incentivize or make it rational to invest in preventative health, or will that always be the government's? And this is also then in the context of what I would call trade-offs in terms of economic growth, and this is something that we've seen quite a lot, like in the Ministry of. You have like the SDGs, you have contradiction, you have a mission from UN going to the Ministry of Finance saying you need to keep your markets open, like here's a great tobacco company, here's a great oil company that will grow your economy so you'll be able to spend more on health. At the same time, the Minister of Health, who usually is not the most powerful person in the room, may be pushing back, but equally, everyone wants growth. So investing in, how could you imagine like a private healthcare company even investing in public health prevention more, because I think that should be possible. Maybe that's one to put to the network as well.
If there is money, if there's a business case, obviously the private sector will be interested. I think one areas I see is really a tech-based, tech-based system whereby you have information and people can pay to access information, preventative information on how to protect yourself against some of these diseases. But for the private sector, if there's a business case, there will always be a case for investing. But I think mostly tech-based, something that people can access, maybe pay $1 or even less, to get information on how best to protect yourself. You talked about the non-communicable diseases like diabetes. Rwanda is doing an incredible. I think they have 1 car free day a month. They also have CMAX on all these big fast food companies. And I think they're doing whatever they can and investing mostly in primary health rather than the secondary before you get this disease. And I think that's why Rwanda is a model for most of us in Africa. If Rwanda can get it right, I think the rest of us can get it right. But you're absolutely right. It cannot just be the government business. There has to be both the private sector and the public sector, and the government must come up with incentives, we say, to attract people to invest in the healthcare. And they're trying to do that. I seem to be very optimistic. They are trying, because they realize you don't, whether you're rich or poor, every one of us is likely to get ill. And if you don't have a system in place, if you don't have the facilities in place, then your money will not buy you.
On that, sorry, I was
No,
going to
no,
spotlight
go.
a startup that does do what you were saying of educating patients called Access Afia. So they've got, it's a Kenyan-based startup, a platform where I think originally they were helping patients with chronic conditions manage them, but I think they've expanded since to educating people on these lifestyle diseases as well. So, the spotlight.
Thank you. I was just going to ask Agnes actually, because someone who has actively navigated the investment environment in Kenya, I don't know if you've worked elsewhere in Africa extensively, but in Kenya definitely, just how easy or difficult is it to...
It is very difficult. I mean, because first of all, I think from a perspective is if 50% of Kenyans have a bit of money to spend on healthcare, we see a business opportunity. I don't know whether it is ethical, but we see a business opportunity that traditionally hospital clinics or healthcare facilities have been run by family. You know, you're a doctor, you have a side hustle where you have a bit of a clinic. It's been very difficult, and I think in my conversation was, how do we scale these little small health facilities and make them, I mean, give them the financing they require so they can scale up and reach other people in the region. It's not straightforward. Most of them are family run, but you're seeing with the interest from private equity fund, them scaling up and spreading across the region. Yeah, but it's like one of the companies, the imaging company, they got funding from a Kenyan private equity fund, but they struggled because it's not always profitable. They've struggled to operate, and now they're looking for more money.
Yeah. I'm wondering how that interfaces that business model with primary healthcare, because
I think that was probably my question actually. Yeah, how do you incentivise investment in primary healthcare?
because I doubt there's much money to be made in primary healthcare in the sense that if it is these
There
small
are
entities.
a few low-cost clinics, again in Nairobi, another startup, which the name, I think it's Penda Health. Their model is to buy lots of small clinics across Nairobi and offer really low-cost care. And they've got venture capital funding, I think on the premise of the return on investment will be delivered at scale.
Yes.
So it won't be 10 sites are super profitable, but 5,000 sites across the continent, then you could be looking at like okay money. So I think that's again, it is always the private sector that seems to be coming in, these startups, social enterprises, that seem to see an opportunity where the government just sees sunk costs. And on the sort of financing, a question that I had, kind of open to the group, is we talked about, you said something about clubbing together to finance healthcare. I wonder what role we think the Africa Free Trade Agreement that has been floated around might play in improving the continent's ability to club together and finance healthcare as a group. Controversial.
We haven't even gotten there yet with the African Free Trade Agreement. I think for me it's more learning from each other's experience. So what is Rwanda doing that Kenya can learn or Ghana can learn? ACFTA has a lot of things to get in order first before we get to even thinking about healthcare. But I think also it opens up an opportunity for investment into the wider healthcare in the region, rather than an investor investing just in Kenya. Perhaps, you know, we can extend that to the wider African region. So for investment from a private sector perspective, it's economies of scale. So if we can have a clinic in Nairobi, how about scaling that into, you know, all the other countries? So it's mostly learning. What do we learn from each other? Secondly, do we are businesses able to access the healthcare in Nigeria or in the respective African countries?
Just to add that, I wonder how, I still feel it's the government that should be front and centre at the heart of healthcare provision. And I feel then they need to be in a position to regulate. It's about regulation, isn't it?
Yeah.
And like you say, government, so I'm kind of totally agreeing with you, but I just, and you see that in the UK as well, a lot of times the private sector can run circles around public sector because it's a bigger machine, it's a bit more clunky, you know, and so it is this innovation. There's some really successful public-private partnerships out there, aren't there? And so there's a way they can work together, but it should be all under the auspices of the public sector is my feeling.
But since we feel miserably from the public
Yeah, but you don't-
perspective, so is it about time then the private sector, who are the African citizens mostly, say, look, it is our health, so we really have to play a very important role in financing totally and making sure that people can have the basic.
So I think there definitely isn't, if I had it, if you've got evidence of where the private sector has gone in and dominated and been a success, because you have lots of the public sectors fail, but you don't have evidence on the private sector part, so it's easy to knock the public
Yes,
sector.
true, you're right.
But, and I don't want to sound like some sort of dinosaur where it's all the public sector, but it's about how can we harness the energy, expertise, finances, efficiency. Some of the business models there, they need to be streamlining some public health thinking, but ultimately I think for the equity issues, for reach, it still has to be sort of the public sector overseeing, should we say, the secretariat.
Yeah, I'm in agreement with that, with you on the public sector being the overseer, and then bringing in interested partners from the private sector.
So I think we've got a question from Michael.
Yeah, it's actually another question, but more a contribution. Now, being Danish, I have lived in Germany earlier and live in the UK now since a number of years. So I have seen the health system in different countries. I think where there's something to learn from is Germany. A lot of the German, it's the public sector basically who finance the health sector. But there is a lot of private hospitals who are actually working as and so closely cooperating with the public hospital and health sector that they have totally normal patients. It's not the classical private thing. It's a close cooperation. And I know, for instance, that I think it's in March, a delegation from public people from Nigeria will come to London in order to attract private health investments for Nigeria. Just as an example. And I have been asked to, Charlie, can you help with finding the impact investors? So, and what I want to say there is, I think this, and that is also about integrated research, connected to solutions on the ground, and working with government, and bringing up the right solutions to pair these opportunities with each other, and not say it's private sector or public, but finding the way how they can merge and optimize and bring synergies together. I think that's what it's about. And we do integrated planning in buildings, so we're used to having this architecture and energy efficiency and carbon neutral and all these aspects, bringing them together in the early stages of the projects, because that's where they will not be economically viable, and high standards of sustainability. And the same thing is in this, it's not just about buildings, it's about everything. We need integrated thinking and optimization. By the way, osteopathy is also about that. Seeing things holistically. And I think that's the key.
That's really
and then we need the professionals to come in there and deliver where they have the best knowledge.
That's really interesting and leads us quite nicely into thinking about our tangible outputs. So we've got a final half an hour, and I wondered if people had any sorts of, if we could leave this room today and do this thing, we will do something that feels a bit more tangible than, a fruitful discussion is always interesting, but what can we do? So does anyone want to be brave and share a tangible sort of task that you'd like to give to the group?
Sorry, let me just add to this. Yeah, on the public health in Africa, I'm going to blame the government. Just the government. Yeah, in Africa, we don't have good government. Do you understand? Now, going to the hospital, I prefer going to the private hospital. Because the government hospital are not caring. Amenities low, nothing to talk about. Mostly the government from Africa, they comes to the UK, Americans, Indians, but the health care.
It's true.
For we masses, we are suffering there. So firstly, we are going to talk about the government to help the health care.
Thank you. That's very true. So what would be a tangible thing that we could do to move things forward? So
I think he told you fire the government.
fire the government.
I'm serious.
That's true.
I'm serious.
He's very serious about it.
Keep them accountable.
Yeah.
And that's, I think, whether it's through voting, which doesn't, has
For example,
but
the
civil
budget.
society.
Look at the budget on health,
Yeah.
4%.
Yeah.
And they're spending $1 billion, and mostly these are the politicians and the wealthy
Yeah.
Nigerians
Yes.
who can afford to fly
Leave the
to
country.
Europe. And I know it's sad,
So
but
I'm blaming the government
Yeah.
for the poor health in Africa.
Yeah. That's
I
very
think
true.
we need to look at where are they some good practice examples of
Mm.
government investing, because I think if we're realistic, at the end of the day, there has to be good government provision across Africa to really reach everyone. And we know, there's so many communities that don't even can't get any access. So it's about, access has to be a priority. And I think we need to find some great examples. Countries like Rwanda obviously is much smaller, and they've been able to address the issue in quite a holistic way. But I think I do have a question around what's the status on modelling of the relative effectiveness of private and public investment in public and private systems to actually start raising the bar on the whole issue of access to healthcare. And I think it has to be combined with Nicole, you were saying about the data. There is such a lack of data across Africa, and there is such lack of systems gathering data, which these days can be relatively easily done, but it's just not built into systems. And as you say, even in some of the private systems, their systems aren't actually. So that kind of basic investment into systems, so that we really have a good picture of what are the actual needs. Obviously, we can use data better to get the flows of medicines into the right place at the right time, and so on. And my personal view is, look at America and look at the UK, and where would you rather have your healthcare provided if you're not amongst the top 2% of wealthy people? To make it a real public service, a fundamental human right, then I think that's where I would want to see more effort put in, to bring out the examples of what's working and see how that can be.
I know you're talking but one question for everyone really, are we correct to assume, which I think we're assuming from this meeting and certainly STDs and all this, do people want free healthcare from their governments, or is that like a kind of forced assumption? Because if you do have money, even the tiniest bit of money, you will avoid the public sector. And of course, it's like chicken and egg. But how do we need to? Maybe that is a next step. Do we need to do more to understand actually what the demand is? Because I think we need to work from that rather than thinking of some utopia, which that's like the UHC utopia, where everyone would get the highest quality care and everyone would want it. But even in the UK, I have friends, if they can get private health insurance to work, they'll take it and they'll avoid the NHS. And this is that's being human. So I think we should also kind of caveat things with even if, and I'm also leaning on what I saw in Ghana, it was it's a status symbol not to use the government the scheme. If you can avoid it, then you will. And I think that we also need to work in this reality when we're thinking about moving forward.
But doesn't that just promote an elitism education?
Yeah.
Do we want education to be free?
Well, do we?
Yeah.
That's the thing, we say, but who are we? So I think that we just need
But I
to always
think
caveat
it's,
that.
like you say, it's a chicken and the egg thing, because you don't want government care not because necessarily you don't want free care, it's because you want decent care, and if that's not on offer, then you don't want that. So I think the human thing would be, because we end up in a situation like America where then if you're poor you die. And so I think on a very human rights level, I think we want to avoid being America, if we can help it.
It is true, absolutely. I mean, why people avoid the public hospitals is because of the quality and effectiveness of these hospitals. So if they were good enough, like the private hospitals, then most people would not want to spend on extra. They're paying taxes already to this government. So certainly they should be able to invest in quality, effective health facilities so that every citizen, whether you're poor or rich, can be able to access this.
You don't want to come out worse than you went in, and I think maybe your experience in Ghana was of the lack of water, but being critically ill. Like in our own family, we've got stories of people getting the wrong blood type and dying. Like that's the stakes. So when you say you don't want government care, it's for a very specific reason. It's not just the lights are out. That's a bit annoying. It's will I come out with something worse or will I come out? So I think that's the stark reality at the heart of it.
But it's a really good question.
It is a good question.
Yeah, what do we actually want? I think, particularly when you're investing in the kind of work I do, we always try and understand what investment do people really need? Do they need hospitals? Do they need shopping malls? What do they really? So the minute we understand, and it brings into your comment about the data and the system to understand exactly what is available, what's working, and using the data that we can be able to make the right decisions in regards to government participation and the private sector too.
Great, so I'm going to take Charlotte's question and then hopefully we can try and do the outputs because I'm keen to experiment with it.
An idea to the book.
Oh, good.
Back in 1984, 85, I was involved in with a contracting company where we worked also together with the Danish development agency, Danida, making mobile clinics, dental clinics.
Mm.
Later, I went with a German group of the government and the church to South Africa. And they have very successfully implemented mobile clinics to the rural areas. Why was this? Because this is about visibility to the data as well. There is a lot of data, of course, and you're really right. Without that, you know more about that than I do. But what I think is if we could maybe combine the local solutions like the mobile clinics and see if we could get them and then collect that again. This train the trainer model that out in the remote areas, that people who should care about monitoring, let's call it that, much data in the community and then spread it that way. I think that could be a model that can work economically and still get us a step forward. And then it's low tech, so it combines with tech, but it's low tech.
I like that. So maybe then an action point of that idea is for somebody to research if someone is doing something like this already, and then we can spotlight them on BOBAB and find ways that each of us might be able to support an organisation like that. Mm-hmm. So does anyone want to take that as their homework?
I would like to involve in it because I see the value and the potential in it.
Look at MSF, Doctors Without Borders, in terms of mobile clinics. MSF, because they go to the hardest to reach places, but they have quite a insular system because they wouldn't, and this is why they criticise, they wouldn't necessarily always coordinate with the national health system, but they have, and they do a lot of innovation as well, focused on humanitarian, but then why should it just stay in the and that's that's
and we need these demonstration projects to learn from and then scale up.
Yeah. Okay. If you go to their scientific day, you can see things like that. Yeah.
Great.
I do think there is a move to get closer to the community, so there's been a lot around community health workers.
Because that's not the one or the other. It's the merge, but still on a realistic level.
Yeah.
I think there's been some interesting work done. I think back a few years now, it was Novartis were looking at the whole opportunity of community health workers who are not necessarily highly qualified, but they obviously have some basics, and how you like the Dixis, how can you bring a higher quality of patient analysis and patient care through mobile, because mobile is growing, and I mean the thought that's prompted for me around the discussion this morning on if we're looking at private versus public is should there perhaps be some further work done on how can the investment of private companies be incentivised by actually helping the public sector more in very, very specific ways, because obviously if we have the choice we prefer good healthcare, and that isn't helping the public sector improve. and you know, they can afford the best doctors, you know, they get best access to drugs and so on and so forth. And something about, you know, getting some synergy between, so that, you know, not exactly a syntax, but you know, that idea that if you have that license to operate in a particular market, there, you know, could be some contribution to helping, you know, whether it's teaching professionals, sharing your knowledge, you know, sharing some facilities, whatever it might be, you know, so they both grow, because I think there's plenty of market opportunities at work for both systems to grow.
Very interesting.
Sorry, that was a comment.
No, that's fine. It almost made me make a comment, but I thought, no, I'm going to be disciplined as well. But that's really interesting. Interesting point. So do we have any more sort of ideas or tangible things that we can take away from today and go and do?
There's one thing I'd quite like to do. Rachel, you mentioned right at the start that your network, because I mean, obviously we touched on it multimorbidity many times, the cost of NCDs, the challenge of integrating them, preventative medicine rather than reactive. You mentioned that there's some challenge around engaging with African partners, or you didn't have enough. But I wondered if there's something we could do together to sort of outreach to or engage with people in our network who aren't necessarily obesity experts but are NCD experts, to see if there's some way to sort of tap into sort of latent expertise on the continent that's could be relevant for you. I'm not sure.
I'm guessing, I mean, this is shifting, certainly from civil society. Like, I think it would be great to, to engage more with, to kind of, I suppose, like, expand like civil society health in Africa to be, which it is already organically, of course, but like, how can we work more and kind of also bring it more to, like, WHO hasn't even been mentioned, really. I think you mentioned World Health once, but it was, how can it sort of fit into this, or actually maybe it doesn't need to, maybe WHO isn't relevant. But I actually went to an WHO Afro event in Brussels, which was talking about the priorities for the region. And NCDs came up, but actually the biggest health issues were they road traffic accidents, which they do classify as NCD, and mental health, especially among youth. So that's interesting as well, because then, and they talked about Ebola and things as well, but actually that's what came up, and that's what WHO is working on, which is good. But what was I going to say? But in terms of, like, I think it would be, we need to get civil society more engaging for us, certainly from obesity. Like, the way I think to do it is around looking at the food environment and access, why people don't have access to healthy foods, why they can't afford it, making that link with then, like, diabetes and chronic diseases, which you can do through information, and that's where you, like, tech, you can bring in, like, social media campaigns and stuff, but actually then getting people a bit angry about that, certainly that aspect of their health, in terms of that they can't make healthy choices as much as possible.
So introductions to civil society, maybe organisations like Access Afia who've got access to lots of patients, and potentially some sort of, I guess, social media or news campaign around this, like a contact them in the news would be useful? Or
well, okay, here's a concrete thing. So we have World Obesity Day, which is on the 4th of March, and it would be great to have a big splash in Africa on it. I believe there might be something in undoubtedly on it. I think South Africa, there might be a launch, there might be an event, but it would be great to kind of activate people around that, whether you're...
Is there a region you're focused on?
No, it's global, World Obesity Day,
It'd be great to publish something on BOBAB in the build-up to that.
Yeah, no, that'd be great,
An interesting perspective I picked up as an event last week on EU Africa, and the agriculture in Uganda, I think. And then she's saying that what they're into farming, they've introduced it now into schools. So schools have their little dairy, and they're actually learning about about farming stuff. And I think going back to obesity and non-communicable diseases and health, then it's, education has such an important role to play. And, one might think a little bit more about, because health is actually part of science, understanding the human body and understanding, nutrition and those kinds of things. So building it into curriculum could be quite an interesting proposition. Perhaps we should give that a little bit more thought.
Interesting.
Yeah, any social media stuff for World Obesity Day in Africa would be a really great thing.
Okay.
That'd be awesome.
So who's going to take that as an action point? So I think Nick can do the BOBAB, like helping you publish something on BOBAB. I can introduce you to Access Afia.
Yeah.
And then the social media thing. Does anyone have any particular contact social media?
Well, I would hope it would
you could just get it trending or something.
No, I'm not sure what it would look like yet, because the World Obesity Day is a campaign actually working with McCann, it's a crafted big global campaign. But I know it's not going to be as strong in Africa because my colleagues don't have as many. We don't have that strong network there, so that's why I think this would be helpful.
Maybe we can take it upon us, really start to build it in the network before March.
Oh yeah.
And how many members we've got on BOBAB, but that everyone on BOBAB should be.
That'd be awesome.
Know about it. That'd be good. Yeah, good idea.
Just as someone who's not looked at obesity, but I hear about diabetes and hypertension, the concept of obesity and being overweight as an issue and a problem. Is the demand at people in that frame of thinking?
Not yet, not enough. But then this is the challenge, because you don't want to blame people, individuals, and also there's a strong cultural element. I mean, I use that with with caution, but it's there's a perception of what a healthy weight is actually unhealthy in terms of your risk factors for NCDs. So there's lots of stuff. But I've had some really interesting conversations. Really end up feeling quite challenged at the end, and it's speaking to it was actually a Nigerian colleague, and he was talking about his personal experience, or actually I think it was his sister. She's morbidly obese, and she's had a horrible time. She gets bullied basically and really stigmatized. But then it's at the same time, everyone knows people in their family that are stigmatized and given loads of grief for being too thin. So it's there's this healthy weight window in which to kind of promote and to do your public health messaging, and it's really hard because of course everyone you don't want to stigmatize people by saying you're a problem, you're an issue essentially. But that's what public health kind of tends to do. At the same time, if you're living with morbid obesity, you are going to have health risks that maybe your family is going to have to pay the consequences for. So it's really, really hard. So we need to just talk more about it, and we need to find out what will work and what it actually looks like from different perspectives, different countries, different communities.
Okay, good. So we've got 2/3 tangible outputs so far. Any more? Or equally, it can be an ask. If you've got an ask, that also works. But if you also have any thoughts that have arisen discussion today.
I have an idea, if I may. I just realized there are a lot of African healthcare professionals working across the UK, Germany, everywhere. Is there a possibility where we can have a database? I don't know how we can go about it, of these healthcare professionals, hopefully with the name of them, maybe providing insights on how African healthcare. Because a lot of us get text messages asking us to donate money towards healthcare. Surely, if we have a database of the healthcare professionals and understand what they're doing and see how they can help. I don't know, maybe it's a bit.
I mean, that's in a way, I guess, sort of the premise, well, not the premise, but one of the outputs of a platform like Medixus is that you could get all the medics in diaspora can also collaborate with the medics on the ground, but equally medics on the ground. It might take me a few years, but I'll take that as an action point.
You can take that. So yeah, there are quite a lot of them. And I can probably I can try and look for the East African diasporans.
Okay.
Through the embassies who is registered and share that with you.
Great.
And you can reach out to them.
Fantastic.
And I have another business case.
Go on.
So I'm just thinking about the text I get about, somebody's raising $5,000. And I thought, what if we had a diaspora health insurance find whereby instead of constantly waiting for this text, say give me $5, whereby maybe I paid $1 a month towards the care of my loved ones at home, rather than constantly getting an email in the middle of the month that I don't have money.
So like pooling remittances.
There is something like that.
Is there, or if there's already one existing?
I think it's called Diaspora Health
Yeah,
Insurance.
so okay. There goes my bit.
Oh, no, that was
I've definitely seen something like that before. But that's
to invite them onto the platform.
Yeah, there you go.
Diaspora Health Insurance. So,
Yes.
So because sometimes you get this text, the middle of the month, you don't have $5, and you feel like if you don't contribute, then people will look at you like, oh, you're not helping. And most of us really.
All right, so
And
I'll
you said you were
send it to
GP,
you.
so you could help with the diaspora.
Yeah.
I often go back to what you said. I think with the data issue, I think I've noticed that there's a lot of people that I've met in the UK that do a lot of work back home in Africa, and they get mentioned quite a lot in research papers. You can read about them in Lancet and things like that. But actually, research that's done back home, it's not a lot, but what's already done isn't well. It's not published. And I think it might be useful to try and connect researchers if it's possible. Here and there, and try and sort of motivate them and help them, encourage them to sort of put work out and try and make their data a bit more.
I think you've got an expert in that here.
Yeah, well, that's kind of our vibe actually, because and we've just got an interesting project actually come on board, the platform which I encourage you all to check out, called Afrique Archive, which is an open source and community-led digital archive for African research. So across the continent, there's a dearth of African-led research conducted in Africa. It's chronic for all sorts of reasons, underinvestment across the education system, but also inequity in research funding, not enough going to the continent. So yeah, I'd first of all encourage you to check those out, but it's certainly something I'll happily pick up as a mantle, because I'm really, really keen for BOBAB to always be great research happening on the continent. So rather than it coming from the other way, it's coming this way, which is really, really interesting. It's kind of what Spotlight Seminars we're inspired to do, is to sort of showcase great stuff coming from the continent. And on that, a second output I'd like to make myself responsible for. It was talked about earlier, the idea of translating, making it easier to engage with, because I mean, I've ploughed through many sort of quite dry research papers, and they're great for the academic community, but useless if you're a policymaker, and almost impenetrable if you're a NGO worker. But there's lots of really interesting stuff there. So we want to play a role in sort of translating research and making it more accessible. So yeah.
How are you going to do that?
So, well, I was going to actually, not at all. Some research is impenetrable at all. But what I was going to say is the sort of starting point with regards to this output is perhaps you and I sit down and do a little interview. We'll talk about your research, talk about some of the data, but do it in a setting that means that people can digest it quite easily and quickly, and hopefully more people see it. So that's something I'd like to.
Podcasts.
Sorry?
Yeah,
A podcast, yeah, great, yeah, that kind of thing.
That's my plan for next year. I want to do podcasts.
Oh, come on board.
I have no experience, but it's what I just think it's great, yeah, for translating evidence, but also for like exploring like all these certain issues around like obesity and chronic diseases, where it's not like black and white for policymakers or for anyone.
Yeah, well, there's something actually from a boring development perspective we're just working in right now. So being not just hosting videos, but hosting audio. So yeah, definitely look at doing some sort of podcast series where you look at translating research for policymakers. We'll need to work on a name. It probably needs to be slightly catchier than that, but something along those lines where we sit down with world leading experts, academics about, anyone in any country can sort of certainly submit audio and things, and then you could be the ones to like curate it, exactly. But so it's not just people sitting in London talking, it can be guests. Yeah, absolutely. Yeah, no, that's great.
Nice. Oh, this is good. Any more tangible outputs?
How many do you want?
I know, I think we can. People at capacity. Okay, well that's good. We'll stick with these 7. Although I hate odd numbers, so that's going to bug me. 1 doesn't really count, so we'll say 6. And so, yeah, I think what we'll do is get Nick to circulate these with the names, so we're all held accountable. And then if we could all log into BOBAB, and on today's event page, I think there's a chat in the side, so we can do little updates, or if there's any little asks or things like that, like, you know, need a bit of support or advice or a nudge to introduce someone to someone, then we can do it there as well. And now we can walk away from today and think, oh, I've got something out of that. As well as obviously the great conversation and the knowledge. Great, well I think that's it for today, unless anyone's got any, we've got 4 more minutes, so if anyone wants to leave us with any passing thoughts or anyone that had a burning question. I was thinking of doing the mean thing of getting people who haven't spoken yet to say something, hence my eyes are floating over here, but do you have any thoughts or things to share?
I mean, it's been really interesting. It's certainly something that I haven't really been exposed to very much, so public health is something that I've been thinking about for quite a long time. The whole upstream versus downstream in healthcare versus preventative, and the multidisciplinary aspects of that in terms of, you know, the economics and the industries that are contributing to the issues around lifestyle and behaviour diseases, which is essentially what's causing the increased need in healthcare. So there's a kind of, it's a really big kind
This
of
is the issue of talking about the private sector, because we've been talking about like private healthcare delivery sector, but we could also say like the food industry, Coca-Cola is the private sector. So it's that's something I think we also need to be careful of when we're talking about public health.
Yeah, and I've also come from, I've been working in private healthcare for the last 6 years, and I see such a lack of joined up thinking and a real compromise of care because their bottom line is very important. And so I have, you know, lots of questions around it, and when you look at something like a developing nation where, you know, you kind of hope that we can learn from, you know, because we don't have a perfect system, but you could almost see the same mistakes being repeated. So, yeah, I don't know.
Interesting. No, thank you. And how about you, Claire? Any thoughts? Did you have any thoughts about how the work that, for example, Medicine Africa are doing in places like Somaliland could link up with, I don't know, interface with some of the things we've been talking about today?
Yeah, I mean, there was lots of discussion about how you can educate people on the ground about certain health issues, all of which is very applicable to Medicine Africa. I'm sure you know, the platform can be utilised in many ways to kind of do, you know, essentially a platform for connecting people to share information and ideas. So really it can be deployed for any health issues.
We can introduce you two as well then, maybe, actually.
We met at LSHDM the other day.
Done. Right. Well,
I think, so just one more point though. One thing, you know, working in healthcare, I know that knowledge does not equal behaviour change.
That's true.
So that's another issue in itself. It's great to put the information out there, but actually I think understanding a bit more about why people don't change their behaviour when they know that actually it's a potentially life-threatening issue, and quite often the environment has to provide the kind of the cheapest and most convenient way of behaving that is beneficial for good health.
That's a very good point.
I mean, we've definitely not nailed that here at all.
No, absolutely. But actually, in terms of like road traffic accidents, which is like the least sexy thing in health, but it's like we have done well there in terms of getting seatbelts and driving restrictions, and that's like one of the biggest health problems, you know, cause of mortality. And like there's things that
But it's stuff like, you know, movement and diet, which the environment has always provided. You know, before we had processed food, you didn't have to think about not eating processed food, and stuff that was the cheapest was whole food. And you had to move in order to work, you had to move in order to go and get your food. And that stuff, you know, it's kind of, I think it's a bit of a weird thing for humans to do now. We have to make these decisions which we're not really conditioned We've not evolved doing that stuff, so it's quite an interesting.
Very good point.
Maybe I'll share something on lifestyle, something which I find really funny. Every time I go for meetings on government providing opportunities or sharing opportunities in their countries for investment, one of the key themes I keep getting is they'll profile these pictures of the international companies that have invested in their country, and they'll have McDonald's, Starbucks, and I'm thinking, this is a sign of development. Or I've had policymakers talk about, oh, that country is really advanced, they even have a Starbucks. You know, if this is what so development means us adapting to some lifestyle that is not really helpful for us. And both politicians and everybody else says, yeah, if McDonald's is there, that means we're doing very well. We're attracting investment.
But then from the health perspective, that means you're just creating a time bomb.
Exactly. You're going to get more and more cases of people suffering from these diseases. So it's always fascinating. I think it goes more, how do we educate? How do we learn from models that have worked or not worked, and then bring them back to the continent?
Great. Well, thank you, everybody. On that note, that brings us to the end. Now 2 minutes over, so hopefully I don't get fired as chair next time. But thank you all for your really great contributions to the discussion. And do make sure, if you haven't already, signed up to BOBAB, because I think pretty much everybody is on there, so you'll be able to find us and connect, and we can collaborate on some of the action points that we had today. So thank you. And thank you, Nick, for all.